Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Head on over to reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great little study guide, great refresher if you're out in practice or preparing for pharmacology exams. So go take advantage of that. Simply an email will get you access to that. Also get you updates when we got new podcasts and content available as well. While you're there at Real Life Pharmacology, go look at the podcast tab. We've done over 300 episodes. I think we're getting close to 400 now. Go take advantage of those previous episodes. Really, stuff doesn't change too much as far as adverse effects and mechanism and all that sort of thing. So yeah, go take advantage of some of those old podcasts. If you're studying a specific topic, you can see on the right-hand side there, we've got them categorized as well. So cardiovascular, for instance, and so on and so forth. So again, go take advantage of that at reallifepharmacology.com. All right, let's get into the drug of the day today, and that is Loxapine. Brand name of this medication is Loxetane. That is an old brand name. There's also an inhalation form called Adasuve, I believe is how it's pronounced. I have not seen this inhaled formulation utilized, but I'll give you a brief rundown on that a little bit as well. So, indications, this medication is used for schizophrenia, bipolar disorder, and agitation associated with those disease states. As you could imagine, this is an antipsychotic. It blocks dopamine 2 receptors as well as some other things. But this is a first-generation antipsychotic, which it probably explains why you don't see it as often. Mechanistically, I alluded to the dopamine blocking action. Certainly this medication has that. Also has some modest activity as an antagonist at serotonergic receptors, as well as other dopamine receptors. We typically think of dopamine 2 as the primary dopamine receptor. Loxapine does have some antagonistic or blocking type activity at a few other dopamine receptors too. In addition to that, it's got some modest, mild to moderate antagonistic effects at muscarinic receptors, so you might have some mild anticholinergic activity, as well as alpha-2 receptors. So if you remember alpha receptors, they play a role potentially in the vessels. And so as I talk about adverse effect profile, you can imagine that blocking those alpha receptors could cause some potential for a drop in blood pressure. All right, so let's talk a little bit, before I get to adverse effects, let's talk a little bit about dosing. Oral and inhalation are both available with this medication. Typically for oral dosing, 5 to 10 milligrams twice daily is usually your initial dosing. That's going to be titrated up often in the neighborhood of 20 to 100 milligrams per day. And again, usually given in split doses twice daily, occasionally maybe given once daily as well. All right, the inhalation formulation, excuse me, this 10 milligram inhalation once daily. It is very expensive. This is a formulation I haven't seen used in practice. There's also a boxed warning that Loxapine inhalation can cause bronchospasm. So obviously in patients with lung diseases, that's very, very concerning, especially. So that's a good little boxed warning there to remember. Adverse effects about the medication in general. So of course we've got that boxed warning on elderly patients with dementia-related psychosis treated with any antipsychotic. Loxapine would fall into that category, are at an increased risk of death. Okay, so elderly patients with dementia-related psychosis, again, we want to try to do everything we can to not use antipsychotics in that patient population, if at all possible. All right, other adverse effects, what are you going to see with this medication? So extrapyramidal symptoms, this is a first-generation antipsychotic, it blocks dopamine 2 receptors fairly strongly, and the stronger you block the dopamine receptors, the more and more likely that you're going to encounter extrapyramidal symptoms. So those movement-type adverse effects that can happen when using antipsychotics. Again, this being a first-generation, probably a little bit higher incidence of those extrapyramidal symptoms compared to second generations. Now, keep in mind this, a lot of this is dose dependent. The higher the dose you go, the more and more likely you may encounter this, for example. GI adverse effects, not too problematic typically. That inhalation can cause some changes in taste. I think that makes a little bit of sense. And then I did allude to some antimuscarinic activity, anticholinergic activity, so some constipation, some dry mouth, that can happen with this medication. Other kind of general adverse effects with antipsychotics, weight gain, metabolic syndrome, it can potentially increase the risk of that. In the grand scheme of things, Loxapine is probably on the lower end when we look at antipsychotics, and then more on the higher end of the extrapyramidal symptoms, which I mentioned. Hyperprolactinemia, that is something that can happen. So if you get patients with an elevation in prolactin levels, that can, for males specifically, that can cause some significant sexual dysfunction, sexual impairment. So something to note there for sure. Neuroleptic malignant syndrome is a rare adverse effect associated with antipsychotics. We can get some mental status changes. Big things to look out for: increase in fever, increase in temperature, if you will. Muscle rigidity can also happen as well. So if you have a patient that has encountered NMS, or you think it's a case of NMS, obviously, we're going to want to discontinue that medication immediately there. Cardiovascular concerns, I'll mention QTc prolongation. Loxapine's probably not as bad as maybe some other agents as far as causing QTc prolongation, but I did want to mention that briefly. So, summing this up from the adverse effect standpoint, why isn't this medication used? Primarily, it's a first-generation older antipsychotic, and we're going to have a higher incidence of those movement-type adverse effects, those extrapyramidal symptoms. A couple things on kinetics I wanted to mention. So that inhalation, that has a peak concentration within a few minutes. Okay, so hence this medication is used for acute agitation. Now this medication, like I mentioned, the inhalation is very, very expensive, so that's definitely a challenge with using it. But we do get those quick drug concentrations in an acute type situation. That's why this medication may be beneficial in that setting. Absorption, this medication is typically very well absorbed orally. Usually not too much of an issue there. Metabolism, this medication is metabolized by a few different enzymes that alter it. 1A2, CYP2D6, CYP3A4, all have potential roles in breaking this down and altering this medication. So it can get potentially a little bit complicated with drug interactions, but generally they aren't going to be terribly significant. With that said, some of those alterations actually lead to active metabolites, which can sometimes make that offset of the drug more complicated to try to predict and figure out what's going on. So in the grand scheme of things, I'm not going to cover drug interactions with CYP1A2, CYP2D6, CYP3A4. It's generally not very significant because they all kind of play a role in that pathway and breaking it down and changing it to an active metabolite. So it's, again, pretty complex, but in the grand scheme of things, it generally doesn't lead to tremendous alterations in concentrations that are clinically significant. Now, if you've got a patient that you start on a CYP3A4 inhibitor or an inducer, and clearly you're seeing a non-response or you're seeing adverse effects, obviously you're going to look at that and say, hey, did this CYP3A4 inhibitor or inducer or whatever we've got, did that affect our drug concentrations, and do we need to make some adjustments? So again, something to maybe pay attention to if you notice some clinical changes with your patient, but not something I'm usually crazy worried about when we start a new medication with Loxapine. All right, let's take a quick break from our sponsor, and then we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material, we've helped thousands of pharmacists pass their board exam, from pharmacotherapy, ambulatory care, geriatrics, BCMTMS, or the NAPLEX exam. We've got tons of content, again, help thousands of pharmacists pass their exam, and we can absolutely help you too at meded101.com. So go check out all those resources, all those links at meded101.com/store. All right, drug interactions. So the first thing I think about is the mechanism. So when we block dopamine, we generally don't want to add other medications that block dopamine. So, Loxapine, we generally want to avoid using duplicate antipsychotics. I think that generally makes sense to begin with. But we've got other medications, such as metoclopramide, that's considered a GI medication used for GI motility, improved GI motility, that has dopamine blocking activity as well. And so really got to pay attention to that when we're using a first-generation antipsychotic like Loxapine, that a drug like metoclopramide can have additive effects on that. On the flip side, if we've got a patient with Parkinson's disease and they're taking dopaminergic type agents like Sinemet, for example, levodopa-carbidopa combination, that can directly oppose the beneficial effects that we're trying to have with that medication. Okay, so important to remember that mechanism, and that's always a good kind of board exam question: is antipsychotics and Parkinson's disease, how the use of an antipsychotic can definitely worsen Parkinson's symptoms and potentially blunt or kind of counteract the effects of a medication like Sinemet, which we use to manage Parkinson's symptoms. All right, common interactions, CNS depressant type effects. So opioids, alcohol, gabapentin, pregabalin, first-generation antihistamines, sleepers like trazodone or Ambien. Loxapine definitely can be sedating with the combination of, causing some dizziness. That can definitely increase fall risk in some of our patients. So definitely pay attention to that for sure. I will add in there the hypotension type effect. So that alpha blocking activity can lower blood pressure if patients are already too low or they're on a bunch of antihypertensives already. That can potentially drop that blood pressure further. So again, pay attention to that for sure there. And then lastly, on drug interactions, I will mention QTC prolongation. Again, Loxapine probably not as bad as some of the other antipsychotics. Ziprasidone kind of comes to mind as being one of the worst as far as QTC prolongation. But with that said, if you have risk factors and other medications, amiodarone, other antiarrhythmics, quinolone antibiotics, macrolide antibiotics, and so on and so forth, all these medications can cumulatively prolong that QT interval. So definitely something to pay attention to, something to monitor for, particularly if you've got patients that have a baseline issue with QTC prolongation and or maybe other risk factors for QTC prolongation. If you want to read more on that, I've got a great blog post from the past. It's QTC prolongation for community pharmacists at meded101.com. So if you just search that, QTC prolongations, Meded 101, you can find that article and just some kind of basic practice pearls, some things to pay attention to about QTC prolongation. So definitely don't hesitate to go check that out. All right, well, that's going to wrap up this episode for today. Thank you so much for listening. Do me a huge favor, leave me a rating review on iTunes or wherever you're listening. Also share us, friends, colleagues, shoot them an email with a podcast episode you found helpful. Definitely spread the word. I greatly appreciate that. It helps me grow the audience, helps me teach more people, which is ultimately my goal. With that said, if you want to reach out to me, comments, suggestions, mededucation101@gmail.com. You can track me down and connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. And with that said, thank you so much for listening. Take care, and I hope you have a great rest of your day.